Alopecia, also known as hair fall. Absence or loss of hair, especially of the scalp. Pathophysiology of hair loss. Production failure, failure to produce or continue to produce a normal hair follicle. Aberration of normal hair cycle, destruction of hair follicle. Classification of alopecia: focal hair loss. Non-scarring. Abnormality of cycling: alopecia areata, syphilitic alopecia, production decline, androgenetic alopecia, triangular alopecia, hair breakage, trichotillomania. 2. Tinea capitis. 3. Traction alopecia. 4. Primary or acquired hair shaft abnormality, alopecia areata. Please have a look at the picture. Approximately 1.7% of the population will experience an episode of alopecia areata during their lifetime. Exact cause is still unknown. It is an autoimmune disease mediated by the cellular arm like T cell, macrophages modified by genetic factors like HLA-R4, DR11, DQ7, triggered by environmental factors. Trauma. Neurogenic inflammation. Infections, agents, etiopathogenesis. Please have look at the flow chart. 4 distinct stages of alopecia areata: acute hair loss, persistent, chronic, baldness, partial telogen to anagen conversion, incomplete recovery, normal recovery. Rapid and complete loss of hair in one or several patches. Site: scalp, bearded area, eyebrows, eyelashes, and less commonly other areas of body. Size: patches of 1 to 5 cm in diameter. Exclamation point: hair at the periphery of hair loss. There are broken hairs, whose distal ends are broader than the proximal end. Few resting hairs may be found within the patches. Going gray overnight: a mysterious phenomenon is observed in fulminant alopecia areata. In about 10% cases of long-standing extensive alopecia areata, some nail changes develop extensive patchy alopecia areata. Diffuse pattern of hair loss in alopecia areata. Alopecia totalis, total loss of scalp hair. Alopecia universalis, loss of entire body hair including scalp hair. Ophiasis, loss of hair confluent along the temporal and occipital scalp. Sisyphal, loss of hair of entire scalp except temporal and occipital area. Alopecia universalis. Alopecia totalis. Ophiasis pattern. Ophiasis pattern of alopecia areata. Higher incidence of alopecia areata in patients of atopic dermatitis, autoimmune disease, SLE, thyroiditis, myasthenia gravis, vitiligo, lichen planus, Down syndrome, tinea capitis, trichotillomania, secondary syphilis, congenital triangular alopecia, alopecia neoplastica, early lupus erythematosus. Spontaneous recovery is extremely common for patchy alopecia areata. For localized patchy alopecia areata, steroid, both local, intralesional and topical, and systemic, in short course. High-potent topical steroid used as first-line therapy. Intralesional steroid given at 4 to 6 weeks interval. Systemic steroid, short course. Topical 1% anthralin cream applied for 15 to 20 minutes and then shampooed off the treated side. 5% topical minoxidil as a single agent or as an adjuvant with topical anthralin. PUVA. Contact sensitizer. Squaric acid dibutyl ester. Diphencyprone. Dinitrochlorobenzene. Psychological support. In extensive scalp hair loss, cosmetically expectable alternatives. Healed alopecia universalis after PUVA therapy, poor prognostic marker. Early onset, prepubertal. Extensive involvement. Prolonged duration, 5 years. Aphiasis.